Guarding the Air We Breathe, Updated Findings, Technologies, and the Space Age, with Dr. Don Cohen, Dr. Scott Cohen, and Dr. Fiona Collins, sponsored by Health First and Active Pure Medical. Quick disclosure, members of the Health First Medical Advisory Board would be myself, Dr. Don Cohen, Dr. Scott Cohen, and Dr. Fiona Collins. I am a full employee. Dr. Scott and Dr. Fiona are members of our advisory board. Next. As you can see what our learning objectives are, on the completion of this, participants will be able to obviously review the latest findings on air quality and airborne transmission of pathogens, list current recommendations and regulations, including those pending, and describe current options for air decontamination and how to optimize air quality.
Okay, well, thank you very much. This is Scott Cohen. I'm a family physician from Central New York, and I will start us off here. I think everyone is well aware that the infection rate, across the nation has really increased dramatically, although it looks like we are in a downswing now with about a 30% reduction over the past month. But part of that has been because of Delta and other variants with their increased transmissibility, and I think we've all heard about that almost ad nauseum, so we're not going to get into that too much here. I will say, as a family physician, I like to remind people, and I'm also a public health medical director for one of our counties in New York, but the vaccines still offer good protection, and I do encourage people to continue getting vaccines, even though they're not a sterilizing vaccine. By that I mean it's not like the MMR vaccine that pretty much absolutely prevents disease. They're very good vaccines at preventing death and hospitalization. So we do strongly encourage you and your staff and your patients to get these vaccines. Remember that transmission to others can occur either with or without the vaccine, although there is some evidence that transmission is likely reduced if you get the vaccine, and that breakthrough infections, do occur with the vaccine. That does not mean that they're ineffective. Remember that unvaccinated children are still at risk, although the children over age 12, the vast majority in the US now have been vaccinated, and it looks like Pfizer is going to get approval for 5 to 11 by the end of this month in October of 2021. So that is really amazing. Remember, there are still, unfortunately, some hospitalizations and deaths, even with patients who have gotten vaccinated. But those are mostly folks who are severely immunocompromised, the vast majority. If you look in my area here, we did a study recently, and 92% of people in an ICU for COVID were unvaccinated. So those are, pretty good numbers, to say the least. So next slide. Okay.
Yes, so I think one of the other interesting things when you're talking about breakthrough infections is there have been about between 5,000 and 6,000 deaths due to breakthrough, which is nothing in comparison to the people who are not vaccinated. And to your point, Scott, it's largely immunocompromised, and the majority were in people 65 years of age and older. When we look at airborne transmission in general, of course, we've all been focused on COVID-19 lately, and quite appropriately, unfortunately. However, I think we need to remember that there are many other airborne microorganisms that carry a risk for transmission, and we can see here just some of them. Obviously, we're familiar with COVID-19 and what's been entailed there, but if we look at something like respiratory syncytial virus or RSV, there are more than 3 million cases a year. Now, they're mainly in the under age 2 years, but additionally, older adults with heart and lung conditions can suffer from severe infections. So that's, again, to some extent, a similarity. So this is of concern. You'll notice it says, what should concern us most from here on? That's a really difficult one, because we really have to look at, can you prevent it? Are there vaccines? How transmissible is it? How virulent is it? And what do we have in our treatment bucket that we can treat people with effectively or not? If we look at Candida auris here, that began spreading in the US about 2015. We've seen increases in cases since then. It's considered an urgent threat. And if you read the news recently, about a couple of months ago, there were 2 outbreaks, separate outbreaks. And the unfortunate reality of those outbreaks is that they were not only resistant to antifungals, so they were resistant to all antifungals. So there really was no treatment available other than palliative care. So obviously, what should we be concerned about? We really should be concerned about all of them to varying degrees, but there are all of these other factors to consider.
Yeah, and Fiona, I think the reason this is so important to me as a practicing physician on the inpatient and ambulatory side is these up and coming infections. Remember, we used to be really worried about MRSA, MRSA, methicillin-resistant Staph aureus, and CRE, VRE, and all these other resistant organisms. There are more and more every day, and we've talked about this in some lectures we've given before. It just seems that we really have to work on, as drug companies are doing, developing new antibiotics and reduction of inappropriate antibiotic use. But also, I think environmental controls are becoming so much more important to prevent transmission. And that's kind of what we're talking about today because of the number of different pathogens that are out there now.
Yeah,
Hey,
and
Scott,
of course,
if I could just throw in there, one of the other things we've been talking about, and we also were involved in a discussion on this, is that antimicrobial stewardship is so very, very important. Because as we look at some of these more resistant organisms and as they develop, that's all really in our hands as providers as to how to help deal with that.
yeah, it absolutely is. And you look at people who were prescribed antibiotics that are no longer recommended, prescriptions that were for broad spectrum antibiotics when they could have been narrow. And of course, recent findings in the evidence base that has caused those changes in antibiotic stewardship. So it's a much more conservative approach. Scott, I know you see this in your daily life.
Yeah, absolutely. And it's funny, we, and Fiona and I, for the audience's sake, we have given some talks on this. A lot of the antibiotics used in dentistry and other areas where prophylaxis is considered are overused. When we gave a lecture, we talked about, the number of cases that used to require antibiotic prophylaxis for hip replacements, knee replacements, heart valve abnormalities, and the vast majority of those we don't recommend it anymore. And that's because of developing, some of these resistant infections. Also, it's not necessary. And also some things even like Clostridium difficile, C. difficile, which is a horrible GI infection that oftentimes takes an inordinate amount of treatment to cure. So definitely something to think about. Absolutely.
Yeah. So next slide, please. So there are several things to consider with respect to the airborne particulates. And so I'm going to handle the first 2 of these, and then Scott's going to handle the third set of questions. So what size are they? What size are the airborne particulates, and what do they contain? Well, we're obviously looking at pathogenic microorganisms. They're contained in larger particles. As we look at larger particles in general, it's generally believed that large particles settle out rapidly, but it's actually quite a gray area, and it's not as simple as that. If we look at spatter, it contains particles larger than 50 microns, and there are droplets that are larger than 20 microns contained in aerosols. Those generally are believed to behave ballistically. But if you really look at it, there was actually a study, and it was on exhaled breath, and they were looking at the droplets that were between 60 and 100 microns. They were actually carried further than 6 meters. And that's really contrary to what we would generally believe. So the size varies greatly. One of the problems is that the droplets rapidly dehydrate in the aerosol and become the droplet nuclei, which can be up to 10 microns, but are largely, unfortunately, as you'll see when we discuss the effect of size on inhalation, the majority are actually less than or equal to 5 microns. So that's a significant concern. Obviously, they can contain viruses, bacteria, fungi, as well as other contaminants, of course. If we look at, well, is it highly transmissible? Well, some of the ones that we just saw on the list are definitely highly transmissible. Measles, of course, springs to mind, as well as influenza, and more recently, the Delta variant of COVID-19, which we'll look at shortly. But the other question, of course, is you could have something that's highly transmissible, but with low level of virulence. So people are still walking around. You could also have something with a high level of transmissibility that causes the mild disease, they're walking around, or it could be extremely severe disease. But there could also be a mild phase when they're still walking around, then severe, causing death. That's the worst of both worlds. And with that, I'd like to hand over to Scott to discuss the third set of questions we have here.
Yeah, thank you. Fiona, I was reading just yesterday about dehydration of particles. And, we think some of these large droplets, they'll settle out quickly. And I was surprised, too, that there is some evidence that these particles can be, much further, carried much further than we thought. But even more important to me it was pretty amazing that some of these larger particles can become small particles and stay suspended much longer because of dehydration. I wasn't aware of that before. Very neat. So the next question, I guess, is, what do we do? How do you handle things differently? So in my world, before COVID, let's just forget COVID ever happened. If a patient had a cold, as Fiona said, its virulence rate is pretty low, meaning it's not likely to kill you, but transmissibility is very high. There's no vaccine for colds, but the relative harm is low. The cost to society, if you look at total cost, meaning missed work and meds and things like that, is actually pretty high for the common cold. But then we look at things where, like TB. TB has effective treatments sometimes, unless it's a highly resistant organism. There is a vaccine for TB. We don't use it in the US for the most part, at least not for TB anyway. But so we have to compare those things and say, where are we with this bug to decide really how we have to treat it? Is it strict isolation? Is it mass? How is it transmitted? How is it aerosolized? Is it a droplet? Is it topical? Is it, hand to mouth, that sort of thing, fecal oral route. So these are all the things we think about when we're talking about airborne particulates and other modes of transmission. And honestly, what would we really like? We'd like something that killed everything that was a pathogen. Probably not 100% possible, but at least for airborne things, I think we do have some really good things on the market now. So next slide. So this one, luckily, we're in a little bit better stead now. If we had pulled the newest one, luckily this last wave is better than it had been, meaning we, as I said before, we have a significant reduction in COVID cases now compared to, just 3 or 4 weeks ago. But Fiona, I was also reading yesterday about this 2-month cycle and how epidemiologists just don't understand, why are we getting these peaks and valleys about every 2 months? Is it that, that's how long it takes to run the course of the new variant through the population? Is it that's how long, strong immunity lasts with infection? Have you read about that? Do you have any thoughts on it?
Yeah, I did actually. And in fact, they found a similar pattern in the UK because, as you know, the UK had the Delta variant to a greater extent prior to the US having it to the extent that it does. And they found there shortly thereafter they lifted the most severe restrictions that the numbers were dropping off. And really they were dropping off in a similar fashion to the number of drops that we're now seeing here that you spoke about earlier. So it does appear to be a pattern. As we look at the trends here, though, we can clearly see the effectiveness of the vaccine once people started receiving that, and the huge drop from the beginning of January down to March. And I think we probably all became a little complacent once we'd been vaccinated, and as a country probably became somewhat complacent. But of course, as we've now seen, it just takes a more transmissible variant to arrive, and there's been an upsurge again because of that. As you said, fortunately, it's now dropping off. The question really becomes what other variants are coming? Are they going to be less virulent? Are they going to cause less severe disease? Will the vaccines still be as effective or less effective? I suppose the good news on that end is even if they are less effective with the types of technology we now have for vaccines, it at least is quicker to develop a new vaccine than it ever was in the past.
Yeah, that's very true. Well, let's move on to the next slide. Speaking of developing new vaccines, one of the things, we've realized, so I try to liken it when my patients ask me these questions, what is a variant? And I just use the H1N1 analogy from several years ago when, we had an outbreak of this, much more deadly H1N1 flu variant. The companies that produced the vaccines were very quick to produce an H1N1 supplemental vaccine. And a lot of people got 2 vaccines that year. I would think about it that way, that it's still the flu virus, in this case, still the COVID virus, but it does have different antigens on it. So maybe not quite as effective with the original vaccine antigens. But if you look at the number of people who have gotten the vaccine here on this slide, that is, pretty amazing to say the least. And there are thoughts now that likely, or at least that there's a possibility that we won't see another mega wave because so many people are vaccinated in the US, especially with kids about to start getting vaccinated from ages 5 to 11. Fiona, do you want to talk at all about the boosters?
I could talk about boosters, yes. So at the moment, as everyone's probably aware, the booster for Pfizer is available for people 65 years of age and older, people at high occupational risk, which of course would include healthcare professionals who have direct patient care involvement, and then people that are younger than 65 who have significant risk factors. So that's the booster that is currently recommended. It was discussed by the FDA and then recommended by the CDC. The Moderna booster is actually undergoing or the potential Moderna booster, I should say, is undergoing a review at the same time as they're also looking at 5 to 11-year-olds having access to the vaccine, which would make a huge difference. Going back to your point about the success, it would be great if even more people would get vaccinated. The other aspect is, of course, people who have had particularly the recent Delta variant. There have been so many in a very short period of time. So we're getting to the point where we not to rest on our laurels, but greater immunity because a significantly higher proportion of the population has been immunized, hopefully with 2 doses if it's a 2-dose vaccine. Also, the procedure for looking at boosters is going to help. And the other aspect is that people who have had the disease also have acquired immunity. So we are getting we're not at herd immunity, but we're getting higher levels of immunity than we've had.
Absolutely. Thank you, Fiona. The next slide.
So here we can see what has happened. We had the alpha known as the UK variant, which was first discovered in the UK. And we can see that's the blue bars. And so that was the dominant strain in June. But then we saw that the Delta was increasing. And at this point, it's almost 100% of all cases are the Delta variant. There are very few that are not. And that's across all states at this point. Going back to the transmissibility, compared to the original strain, it's estimated, depending on what data you're looking at, between 2 and 2.5 times as many infections are caused by the Delta variant, spreading more quickly.
Hey, if I could ask, I noticed today when I was reading, there was a discussion about holiday precautions, holiday party type precautions. And it seems like we're going back to the masking and the social distancing and so on. Any comments or thoughts on that?
I can give my comments, and I'm sure Scott can as well. My comment at this point is there are some breakthrough infections. It depends on whether everyone's been vaccinated, if there are any at-risk people in the group, but also think about, do you have at-risk people that you see, whether it's family members or other people who perhaps cannot be vaccinated specifically for medical reasons? or they're immunocompromised because of medical conditions. So I think we all need to be careful in thinking about those people and trying to avoid infecting them. That, of course, at the moment also applies to very young children, as well as the 5 to 11 group who at the moment can't receive the vaccine. So I think those are really important considerations. That if you're outside your own little bubble, to really take these extra precautions. I know it can seem irritating when we weren't wearing a mask for a while, now we are. And personally, I find it irritating when people won't get vaccine but don't mind availing themselves of the facilities once they are sick. But nonetheless, I think we all should be responsible citizens and help look after each other.
Yeah, I completely agree, Fiona. And as a healthcare practitioner, my worry, is that I'm going to, get COVID and then unfortunately give it to a baby or kids. And honestly, our local pediatric ICU had really no kids during the first wave, in 2020, and recently has had a fair number of children, including a pediatric death. And, honestly, my biggest worry is giving it to others. So especially those who are unvaccinated or haven't completed their vaccine series or can't get vaccinated, or, are likely, under immune because they're transplant patients on immunosuppressives. So I usually tell people, if you're going to a big event, I would certainly wear a mask. If you are somebody who, lives with someone or is around someone who's at ultra high risk, like a transplant patient, someone with COPD or something like that, I would certainly take some precautions. If you don't have any of those situations, you're going to get together with 4 or 5 people who are all vaccinated, I would say that's a lower risk scenario. Not no risk, but lower risk scenario.
Yeah.
Okay, next slide.
Okay, so here we go back to how long can they remain in the air, how far can it travel, and then some of the other considerations. So if we look first at how long can it remain in the air, it's staggering actually how long it can remain in the air, and it's much longer than we thought, depending on the size of the particles. So if we think about what they do with studies is they look at unit density spheres, and they use a diameter of unit density sphere to assess how long it takes for that particle size to drop out of the air and settle. That's the same velocity as the one that you actually would like to look at. So it's a proxy way of looking at the settling time. What we've found is that for half a micron size, it's about 41 hours. So it's incredibly long period of time. It already drops to 12 hours if you go to 1 micron. And by the time you get to 10, it's 8.2 minutes. So it is not a linear scale by any means. And the smaller the particle, the extensively longer period of time it will remain in the air. And that then goes back to the next part we'll talk about, how far can it travel? So if we look at studies, again, it was generally considered that it was about 6 feet for droplets. But the droplet nuclei, the dehydrated particles, can travel much further, as can some of the larger particles. There's actually a couple of studies that were conducted quite a considerable time ago. One was a gentleman who, with his colleagues, looked at a multi-chair clinic. It was a dental clinic. They had 4 chairs. At one chair, no treatment was being performed. And that chair was at least 30 to 34 feet away from any of the chairs where treatment was occurring. And although the level of contamination was significantly much lower than for the chairs where treatment was occurring, nonetheless, the level of contamination did increase during the treatment day, in spite of the fact that no treatment was there. So that was an example of 30 to 34 feet. There's another study by a gentleman called Al-Maglouth and his colleagues, and they found contamination that was surprisingly severe in terms of these surfaces and the area. And this was 2004, and they already were saying that we really need to be mitigating aerosols. So in short, they can travel further than they would like, much further, and they remain in the air much longer than we thought. With that, I'd like to hand over to Scott to talk about what happens based on the particle size.
Yeah, thank you, Fiona. We were talking about particle size and how far they can travel, but interestingly, it's analogous in the human body. We know that particles, less than 10 micrometers in size, are generally, inhaled into the upper respiratory tract. They can reach below the glottis, but those less than 5 micrometers in size, will really get all the way down into the respiratory tract and cause initially lung-based infections oftentimes. And we're talking about things like particles that contain multiple different types of viruses, not just, COVID or the flu. But also, I was kind of surprised to read that some of the bigger particles, like bacteria like Pseudomonas, which is something that us doctors just absolutely hate. It's really a nasty bacteria, but even they can be carried down into the lungs with smaller particles. So it is worrisome. And that said, sometimes our treatments are changing and sometimes our treatments are ineffective, as Fiona said, with things like, fungus like Candida auris, because these organisms mutate. So for example, the more we give antibiotics, we actually, select out, Darwinian selection almost, for those bacteria who are resistant. So it may be one bacterium, in a million or even a billion that happen to be resistant to ciprofloxacin, for example. But if you kill off all of the other bacteria that are sensitive to Cipro, guess which one survives? And guess which one propagates and then becomes the dominant species? It's the one that's resistant to Cipro. So what we're doing is we're creating these, quote, superbugs by over-treating oftentimes. And that's antimicrobial resistance. There's things where, other like plasmids can get into bacteria as well. But the reality is we can do better by, number one, environmental work, by, reducing bioburden on surfaces and in the air, but also by not over prescribing for antimicrobial therapy. So next. So we're going to talk briefly here about, we talked about what some of the bugs are, how they're transmitted, what some of the distances are that these different size particles can make. But how is this a risk for patients and healthcare personnel? We all know, we talked before about the COVID-19 surge with Delta, higher transmissibility. The level of vaccination wasn't, great when this all first started. And there's also more and more mutations. Remember, we talked about overprescribing of antibiotics causing mutations, but what else causes mutations is just reproduction, meaning as viruses or bacteria continue to reproduce at high levels, they naturally have mutations. And those mutations are generally selected for, meaning that that organism propagates more than its brothers and sisters if it confers some sort of survival advantage. So don't forget that, there's things that just by getting diseases and having them continue on and on, that causes further mutations. So when you hear about, there are second and third world countries that have, 5 or 10% of their people vaccinated or less, those are actually contributing to new variants or new mutations. So it is very, very important that we not just vaccinate in the US, but we get vaccines out there to, all nations that need it. And, Fiona, do you want to talk about like the pattern of spread and season and things like that?
Yeah, so when we think of the pattern of spread, we can look at it in a microcosm, but we also can look at it in a macrocosm. And if you, the world's small, so if we don't have people in different countries vaccinated, it is going to spread. And it doesn't take long to go from one place to the other. On a more local micro level, need to look at where are staff located, where are patients located, what about break rooms, where is it all right for staff to be unmasked, what can they be unmasked? So recently CDC came out with revised recommendations. And so you can consider no source control. I'm not recommending, but you can consider no source control for staff if they're in areas where patients are not present, cannot be present, and if you consider that everyone is fully vaccinated. But there are other methods. There are methods of source control, of course, with masks. Depending on what you're doing, a respirator may be used. And then there are additional steps. So as we look at that, we're talking about transmissibility, we're talking about virulence, we're talking about vaccination, and all of these other ways to help prevent disease. But we also really need to look at, well, how many of a particular microorganism does it take to cause disease? That's still not entirely clear depending on the microorganism, and that includes COVID-19. So what's the minimum number? How many need to be present? How long does it need to be present for? It can very, very quickly get into the anterior nares and the nose. And of course, it's a small particle size. So to Scott's point, can rapidly reach the lower respiratory tract in a droplet nuclei. And so really, as we look at that, we need to think about what other steps need to be taken. What else is the CDC recommendation? What else are they recommending as adjuncts? And what else might we consider doing to absolutely minimize the risk?
Yeah, absolutely. Let's go to the next slide. I'll turn it over to Fiona, but I'm kind of a doer, and it's like, what can we do about this? So we talked about vaccines, we talked about washing your hands and surface cleaning and wearing N95s or other devices. But this gets into the exciting part for me. What can we actually do in addition to that further reduces the risk somewhat dramatically as well? So I'll turn it over to you, Fiona.
Right, so I'll start this then beyond there. And we can see here the hierarchy of controls, and it does state that the least effective is personal protective equipment. I would hate for anybody to get the message from that PPE is ineffective. It is not ineffective. It is effective, and I think we all know that when you think about everything that dental professionals and other healthcare professionals have done, including donning and doffing PPE and using specific PPE as a stepped up approach for protection during COVID-19, we know that it contributes to the efficacy of infection prevention and control. The other ones, administrative controls, when we look at that, examples in this particular situation would be the screening and triaging of patients, changing how you're working. The elimination would be fabulous. Substitution, can you substitute other procedures? What else could you do? Overwhelmingly, really what we've been looking at in addition to PPE and administrative controls, has been the engineering controls. And so 400 dentistry is an administrative control, you're changing how you work. But when you look at high volume evacuation or extraoral suction as well, for that matter, rubber dam, those are engineering controls that actually help to prevent transmission by using devices that reduce the risk of transmission. The guidance from the CDC includes a layered approach, and part of that is ventilation. So Scott and I have talked about ventilation previously. It's really quite interesting. If you look at what the CDC defined as a minimum, it's 6 air changes per hour. And that was the criteria that was considered an efficient ventilation system going back to 2003. If you look at transmission-based precautions, 12 air changes per hour is recommended. And in fact, the minimum of 6 air changes per hour is being reviewed in the US as we speak. It's also being reviewed in other countries, including, for example, the United Kingdom. The assumption had been the air is ideally mixing, there's nothing in the way, and so this was the basis for the number of air changes. But we know that's not the case. And so there are also currently recommendations on how you could improve ventilation. But I think before we talk about how you can improve it, Scott, I know we talked about how can you assess it in the first place?
Yeah, it's funny. I was literally just thinking about that, and I was doing some reading again yesterday about this. I was not aware. So obviously, I was aware that HVACs you can measure airflow, and as a proxy, you can figure out how many turns per hour there is by how many cubic feet per minute are coming in. But it turns out that's not a great way of doing it. And so I was reading again about CO2 levels, and indoor CO2 levels are really a good proxy for how the turns are, meaning how dilutional we're getting with fresh air coming into our offices. I'm not saying that we definitely recommend checking that on a daily basis, but it would be good during a summer or winter season, when it's either real cold or hot and you're running your systems, to know exactly where you are with your CO2 levels. And there are organizations that do that. Fiona, I don't know the thresholds for them, whether you do, but I do know obviously lower is better because exhaled air has higher CO2 clearly.
Yes, and as we know, it's also been used in school systems successfully. Really, it's an early warning system to check on what the level of ventilation is and does it need to be improved at that time. So if we look at CDC guidance, they suggest using fans appropriately to increase the flow of outside air. You could, again, to your point, Scott, depending on the climate, crank the window open ever so slightly. Other options include consulting with an HVAC specialist. Could you do something else with the HVAC? Could you adjust it? Could you adjust and open the air dampers, the outdoor air dampers? There are actually quite a number of methods of adjusting the ventilation. And if you're interested, you can find it on the CDC website. The other thing that we look at for HVAC is the minimum efficiency reporting values, or MERV. So we know about MERV ratings and filters. So there are recommendations for that as well. And ASHRAE recommends a MERV 13 rating. Now, that's 85% efficient at capturing particles between 1 and 3 microns in size. It did note that a MERV 14 is preferred. However, ASHRAE also noted that because HVAC systems are all different, you have to take into account the specific HVAC system in your facility. Yet another reason to consult a specialist. And although a MERV 13 is recommended, depending on your building and the system, that might not be possible because it can actually end up reducing airflow or increasing energy use rather than having the effect of increasing ventilation, which is what we're trying to achieve in filtration.
Mm-hmm. Okay. I guess, as we move on, some of the things that Fiona and I are very interested in is what other adjunctive devices can we use to help this out? Obviously we're talking about filtration, within a room. Clearly increasing ventilation does help, but what methods we're going to talk about next are, HEPA filtration and UV germicidal irradiation, sometimes combined with HEPA filtration. We'll talk about some of those devices and how they can be helpful. And there's a few others as well. We have to have due diligence for these things. I will say, and I've been saying this for many years to my patients, especially COPD patients, please do not use ozone generators. They reduce indoor air quality dramatically, can cause significant respiratory problems, including with asthmatics and COPDers and others. So again, if you hear ozone generators, please don't use those. They are not indicated and they're not helpful, and they can be very harmful. So next slide, Fiona.
Yeah, going back to the ozone generator on this slide, before we move on to the ones that are recommended, they're not only harmful, they're toxic if they have a high enough level of ozone. And both OSHA and NEOSH have permissible levels above which it's considered hazardous to health.
Yeah.
So for OSHA, it's 0.10 parts per million of ozone during an 8-hour work shift. If you look at NEOSH, they have the same limit in terms of level, the 0.10, but they don't recommend this be exceeded at any time. So it's not based on an 8-hour work shift, which is here being used as a day of exposure. The other group that we'll talk about also with respect to some of the other adjunctive devices is the California Air Resource Board, or CARB as it's called for short. So as the name suggests, that is involved in overseeing air pollution control efforts. So that would include these engineering devices that we talk about in California. And so the idea there is that you maintain and reach, before you maintain, if you haven't already maintained it, health-based air quality standards. Mm-hmm. Other government organizations also recommend against the use of ozone generators as air purifiers in any space occupied by people, or for that matter, animals.
Yeah, and one other thing, just to hammer it home on ozone generators, I was reading it takes about 25 times the maximum allowable concentration of ozone to actually be sidal. So it makes absolutely no sense to be using those. So
yes,
Go
And to
ahead.
your point, Scott, there's data on that on the EPA website. And they're saying that based on the evidence, ozone concentrations within the permissible level, which is exactly what you just stated, are ineffective in removing microorganisms. So for it to be effective, it would have to be at a level based on the evidence that's hazardous to health.
Mhm. Absolutely. So, one of the things that we talk about, we mentioned before, there are technologies that capture microorganisms, whether they're intraoral or extraoral. There are some technologies we're going to talk about that use a combination of filtration and destruction, whether it's UV or other. There are, some that actually kill microorganisms within the air, and then, there's a couple others with filtration and microorganisms destroyed in the air, and then filtration and microorganisms destroyed in the device and the air. Interestingly, if you think about that last one I just said, filtration plus the microorganisms destroyed both in the device and the air, sounds like that would probably be the best recommendation, just because it has the most societal effects. And then ozone, again, not recommended.
Yeah, and to go back to the CDC recommendations, obviously HVE is an intraoral method of capturing microorganisms. The extraoral suctions are an option. Again, in their case, it's really going to depend on the design. Is it designed for a close approach to the perioral area? How wide a catchment area does it have? What's the power level and what happens afterwards? So these are all things that need to be looked at. In terms of adjunctive devices, the CDC recommendation is either HEPA filtration or to consider UVGI. For the other adjunctive devices, again, the recommendation is make sure you're using your due diligence before you select and use one. Next slide. Now, as we look at HEPA filtration, again, it is recommended by the CDC. It's also recommended by ASHRAE. It's safe for use while people are present, so continuous filtration. And when we think about that, that's an important point in differentiating different types of devices. If it's working continuously, even if somebody just came in the door and happens to have a virus, so let's say it's COVID-19, since that's what's uppermost in our minds, and they come in and there's viruses going into the air, then and then the next patient's doing the same, and so we go on. If you've got continuous filtration, and it's not only when people are, or continuous treatment rather than intermittent when people are not present, you're also capturing and hopefully killing microorganisms as they're arriving into the environment. So that's helpful. So if we look at HEPA filtration, this is wording from the EPA website, can theoretically remove at least 99.97% of particles that are 0.3 microns in size. One of the myths that abounds, not only for HEPA filters, but also with respect to respirators, but focusing on the HEPA filters, some people think, well, if it's effective for 0.3 microns, it must be ineffective for particles that are smaller. That's not actually the case. The 0.3 microns is the benchmark because that's a particularly difficult diameter to capture. So although that's the part of the definition of HEPA filtration, it will capture particles that are larger and smaller. And Scott, I know you had mentioned already when we were looking at the prior slide that we get different combinations of types of filters in several devices.
Yeah, absolutely. I think in my mind, I would love a device that was able to be on all the time, that, basically, I don't want to say sterilized, but remove the vast majority of the pathogens from the air. Also potentially could work on surfaces if, there was some surface settling, and quickly remove some contaminants that were removed in the air. I don't think anything really does all of that, although some come close. But adding UVGI is very helpful in the sense that it does kill more particles in addition to what gets pulled into the HEPA filter. I think you also have to be a little careful with HEPA filters. It's some experience that we've had in medicine, in that you really don't want to draw contaminated air across your patient or across your staff. So you really have to be careful with how things are placed in a room. They also can be loud. So I think there are definite good things about them, but they have their drawbacks as well.
Yeah, the majority seem to be okay from a noise level, and you can ask the companies about decibel levels, and that applies to the other devices as well. So you're looking for something that's quiet, works smoothly, works effectively, and works safely. I think the other thing to be aware if you're looking at HEPA filtration is there are some that are called HEPA RX or medical grade RX. There are all sorts of adjectives used. Those are not definitions. They're not accepted definitions. So if you're looking, it's the same as any other device. If you're looking at a specific device, you want to know it's been shown to be effective. And you also want to understand what's the noise level, how large an area can it treat, and everything else about that particular device before you make decisions.
Absolutely.
Going back to the UVGI that you had mentioned, Scott, obviously we do have the induct devices, but there are also full room and upper room devices. Now, UVGI is hazardous in if it's full room UVGI, either it needs to be a space where nobody is present, which means it cannot be continuous, and special protective clothing. If you look at upper room UVGI, that's able to be used continuously. Again, you need to look at the room configuration. What's the height of the ceiling? That makes a difference. Where are they mounted, on the wall or on the ceiling? Again, it can be used in an occupied space, but the other thing to consider is what's your environment? How well does your air mix? And we talked about air mix and ventilation, but it's also applicable in UVGI. The reason you can do it in occupied spaces is because it's upper room. It's ultraviolet germicidal irradiation in the upper room. So you're irradiating the upper area away from people. The lower area of the room is where the people are present. But in order for it to be effective, you have to have a mix of air that goes from upper to lower and vice versa. Because if you don't do that, you've got stratification and you've irradiated the upper air, but it never reaches the people in the lower part of the room. So again, make sure that you have an environment where this will be effective. And again, there are specialists that will help you look at this as well as other devices.
All right, next slide.
So we've talked about due diligence and having data to support efficacy and safety for the other potential adjunctive devices. And Scott said, well, he'd love to have something that will work all the time, that will be effective in reducing contaminants. And so those are important considerations. The others are, has it been cleared by the FDA as a Class 2 medical device? In order for that to happen, there's a huge amount of data that has to be submitted for that device. So that means it's gone through a pretty thorough review. Is it CARB certified? We talked earlier about the California Air Resource Board. So if you look at some of the adjunctive devices, some of them have actually been tested and certified by CARB. So that's another consideration to look at, quite frankly, even if you're not in California, because it is a certification process that looks at the safety of these devices. Again, continuous or intermittent. And Scott, we have other considerations here as well, which I don't think we're going to go into in this particular presentation.
No, I don't think we have to, but just realize that each of these has very specific specifications in terms of what they do, how they do it, and what room space they're available for, and of course, whether they're safe for continuous use or not. And cost, of course, is always an issue. So next slide. Okay, I can talk about these, Fiona. You know, the ESP air purifiers have been around for years. And what do? They capture microorganisms by charging the particles. And it is kind of neat if you think about it, how someone thought about this. But what they do is they pull air in, similar to a HEPA filter. And because the air runs between charged plates, any particles in the air become charged and they get deposited on a collector. And these just get, washed away from the plates during, routine care. I think I've seen some of these too. I don't know if you have, Fiona, that also have HEPA filters built in, but they're pretty basic and they do work and they're probably about 99% effective. Anything more on that, Fiona?
Not really. It's really a question of opposites attracting, a bit like a magnet. So you've got the charged particles and then the plates with the opposite charge. I think one thing that we can note is that there is regular care required to wash away the contaminants that have been deposited on the plates. But to your point, Scott, they are effective.
Absolutely. That's true. I forgot. You do have to clean these on a regular basis. They don't actually kill microorganisms. They filter them out by causing them to be charged and then stick against the opposite charge plate. So you do have to clean them and be careful, obviously, when you do. Okay, next slide.
So now we're getting into newer devices. We're talking here about the use of gaseous hydrogen peroxide, other oxidizers, and filtration. This particular technology is derived from the technology that was used in the NASA space program. It's in the Space Foundation Technology Hall of Fame. So it is continuous, as was the precipitator, in fact. It's continuous. It will offer air decontamination, and it works, as you can see, in 2 phases with 3 different technologies. So the first part is the use of titanium dioxide and an ultraviolet light within the device that produces gaseous hydrogen peroxide as well as other oxidizers. The oxidizers enter the air and they destroy microorganisms. Now, if we think about oxidizers, I think almost all of us are familiar with hydrogen peroxide. It's an oxidizer. It's one of the oxidizers that's also used in EPA registered hospital level disinfectants in some of them. So we are familiar with oxidizers. This is a gaseous version. So it will destroy microorganisms in the air. The phase 2 involves, it's somewhat similar to regular filtration. Air is sucked into the device. Again, contaminants are ionized, so they become charged. They're trapped once they're charged, and there's HEPA filtration as well within the device. Now, in addition to all of those, because you're sucking air in, at the same time, you're sucking in the gaseous hydrogen peroxide and the other oxidizers that had already been created and had already entered the air. So once in the device, those oxidizers are sucked in with the air and will also kill microorganisms within the device. So as we look at the testing, it's remarkably effective. The first one here on the middle column is the University of Texas Medical Branch, and this was on the technology itself. And they actually were looking at SARS-CoV-2 decontamination. They had a protocol, as you can see, with a delivery of 29 cubic feet per minute of air movement. The actual reduction might have been more. The test went down to 1.6 log reduction. And what they found is that there was a reduction in concentration within 3 minutes, a 99.96% reduction in the concentration of SARS-CoV-2. If we look at other research, you can see an example of some of the other research that was conducted. And this actually used proxy viruses, bacteria, and fungi. So they used a variety of different ones. Some of them were, one of them was Staphylococcus epidermidis, and that was used as a proxy or a substitute for Staphylococcus aureus, including, of course, MRSA. Another one was a substitute for the microorganism causing Black Plague. And then the one that I've shown here at the top, or we've shown here at the top, is a bacteriophage that was a proxy for influenza virus and norovirus. Without going into all of the details, across the board, after 60 minutes, and then sampling, the log reductions before use, compared to before use, ranged from a log 4, which is a 99.99% reduction, to log 6 reduction, which is 99.9999% reduction. And so really highly significant reductions across quite a range of microorganisms that were proxies for pathogenic microorganisms.
Yeah, and Fiona, I was really amazed. I wasn't amazed at how well it worked. I was amazed with the speed at which it improved the concentration of SARS-CoV-2 or proxies in the air. That was the part that surprised me pretty dramatically. And I'm not sure why that is. Is it because of the multiple technologies that caused such a significant reduction with a single pass-through?
Well, really, if you think about it, we've got a phase 1 and a phase 2. It's producing these oxidizers that will kill microorganisms both in the air and in the device. And on top of that, you get trapped ionized contaminants, or ionized contaminants that become trapped, perhaps I should say, as well as HEPA filtration. So it's really a combination of technologies that have been developed from the original NASA space technology over a period of time. Mm-hmm. The one on the right is actually a research on a specific device, and that was the Active Pure Medical Guardian. The research on SARS-CoV-2 in the middle was the technology itself. So I think with that said, it's certainly been shown in healthcare settings. Now, I noticed, Scott, we talked about the number of different places where this has been used. And it's been used at the Cleveland Clinic, but it's also been used in some sporting arenas.
Okay, I didn't realize that. Okay.
Yeah, one was the Yankees, and I'm sure the other Dr. Cohen, Don, would be able to. I know there's another one as well beyond the Yankees.
Yeah, so you might turn off the entire southern half if you only said Yankees. So they actually use this for the Texas Rangers in Texas as well. But recently, there's also a number of school districts that have adopted this as well, simply because of this technology that it seems to be protective rather than simply a filter. I mean, the ultimate kill are these robots with UVC that, go into a room. Of course, you have to lock the room. Nobody can take a chance on being in there, but here's one that you can actually be present in the room. And I look at that as a much safer approach with, again, a kill that, there's been additional testing on bacteria and fungi, because the fact of life is we will eventually get past, I believe, this level of COVID-19 and the variants. We're not going to get past all the futures. They're going to keep coming. So having a device, I think, that has more of an approach for any form of pathogens is probably much more cost effective in the long run. So I like that kind of approach. There are a number of other devices out there, but this is the one I've seen that seems to have a little bit more activity to it for positiveness.
And it really is continuous activity of the device. So you're getting ongoing mitigation and reduction in contaminants.
Mm-hmm. Okay.
Next slide.
Yeah, neat technology. Okay, next.
So this is another one that's interesting. This is the Radicate. This filters microorganisms and other contaminants, and it destroys them in the device. It had a single pass rate, meaning this was the kill rate with the air going through the device once, of 99.9999%. That was against viruses similar to SARS-CoV-2. So this one's been tested on bacteria and fungi in aerosols as well. It's from South Korea. It was used during SARS, and it's been used there pretty much ever since. So as we look at that, this is a closed system. It does not kill microorganisms in the air. It kills them in the device. The other thing to note is it is not an FDA cleared class 2 medical device. However, that being said, it is currently marketed under the FDA's enforcement policy. And that enforcement policy was really driven to make sure that there were adequate types of devices that included sterilizers, disinfectant devices, and air purifiers during the current pandemic. To Dr. Don's point, we will at some point be thinking less about COVID-19, and we will definitely have to think about other microorganisms as we go forward. Really, I think, unfortunately, the only surprise has been it took us long for a pandemic like this to occur. It could have happened a lot sooner. Scott, do you have anything to add?
No, not on this one. Radicate really makes sense to me as well. So yeah, we can move on.
Okay, next slide. So again, really what we're looking at is, are there review studies supporting the efficacy and safety? And we've just seen some that gave robust results. Are the studies independent? Is it effective against a range of microorganisms? Have you got proof that it works well against a range of them? Has it been used in a healthcare setting? And does it have FDA clearance and potentially also CARB certification? So again, these are all parts of the due diligence that should be performed when using adjunctive devices, and actually, for that matter, any device.
And also just remember usability and effectiveness. Usability meaning things like, loud noises of very loud HEPA filters, which most of them are not all that loud, and effectiveness in the space that you're going to use it for. If it's certified for, 300 square feet or depending on cubic feet, I'm not sure how they're certified, and you're using it in a space that's 5 times that size, it's not going to be effective. So you really have to remember where you're using these devices as well. Okay, next slide.
So Scott, I'm going to hand this one over to you.
Okay, absolutely. So, I just think, let me rephrase here. So there are numerous microorganisms that cause concern in our society now. And there are more that are developing every day, every year. So our fight against COVID is not going to be the last thing we fight against. And also, I think COVID is probably never going to go away. I truly believe that COVID is going to become endemic, meaning like the flu. It's going to wax and wane, and it'll have its cycles in the wintertime. So that one will need to be, treated as well. Both, vaccines, there's new drugs coming out for COVID, hopefully. But we really want other environmental controls as well. We have to consider the transmissibility of organisms as well as their virulence, meaning how deadly are they? And also, what are our existing defenses against infection, including vaccines? We need to think too, how resistant is the microorganism? Think about Candida auris, where Fiona said, listen, there are many of these organisms that we find are pan-resistant. Pan-resistant meaning are not treatable with any known antifungal. So it would be much better to prevent infection by using, topical cleaners and, air cleaners like we're talking about here and other environmental controls, rather than trying to find the newest, best and greatest, antifungal or antimicrobial, depending on what we're talking about. Whenever you're looking at these devices, really have to research the supporting effectiveness and safety. Safety is key here. And I think you also have to look to make sure you're using it in the right environment. As we talked about with the UVGI, there are some that are meant, for full-time use, but they have to be high up in the room because of the radiation exposure to UV, and others can be used low down. Remember too, we want continuous and effective risk reduction. If you're going to use, like a UV robot that we were talking about before, those are meant to flash, clean a room of microorganisms. But then the second somebody comes in who happens to be infected, they're recontaminating the room, and you can't use one of those, very harmful UV lights with people in there. So just think about, whether or not you can use these devices continually. So we'll turn it over to Dr. Don for just a quick wrap up, and we'll get some questions.
And thank you, Scott, and thank you, Fiona. A quick question came up, and that was, how effective is the N95 mask in dentistry compared with other respirators? Who wants to grab that?
I think, Fiona, you want to take that one, or you want me to?
Yep, that's fine. So as we look at N95 respirators, they're clearly more effective than surgical face masks. The key really with any respirator is how well does it fit. There was a bit of a myth going around for a while that you don't need to do fit testing. You do need to do fit testing. You can do checks in between, but you do have to do fit testing for a respirator. So if you get a different brand, a new model, for instance, or the shape of your face has changed, maybe you've lost a lot of weight or gained a lot of weight, then you need to test that respirator. Until recently, there was the emergency use authorization from the FDA for non-NIOSH approved respirators. That is no longer the case. That's been cancelled. And so really we're looking at either an N95 respirator. It could be a higher grade NIOSH approved respirator. There are ones that are N99s. There are also PAPRs that have vents inside, and they are more isolation. So they are believed to be even more effective than an N95. But in a nutshell, the key is the fit of your respirator and that there's a good seal around the face.
Great. Thank you. Thank you, Dr. Collins. I thank everybody for attending. This particular event will have CE credit available. You need to follow the course that's involved. I'm going to throw one back at you too, real quick, Fiona. So wearing a surgical mask and a face mask is not effective? Question.
Okay, so I had an interesting question come up in July, and it was basically we wear our N95 over our face mask. Well, in doing that, you've destroyed the possibility of having a good seal because the face mask is under your N95. OSHA doesn't, it's not recommended generally to wear a face mask over an N95. Obviously, in that situation, it's not going to destroy the seal you would otherwise hopefully have obtained. It does make breathing harder. People were doing that while there was a shortage of N95s. There is now a better supply of N95s, and for that matter, many more domestic suppliers.
Great. Again, thank you, Dr. Collins. Thank you, Dr. Cohen. We hope this has been advantageous for all. There's lots of questions out there. We recently did a similar program, and we found out that certainly 80% of the dental population had invested some resources in air treatment. Here's a way to maybe evaluate what's best. The research is out there. It's really important that you evaluate it yourself and see what truly works best in your environment. Thank you. And again, thank you all. Great to get some CE credit and do some really valuable learning about today as well as the future. Because as we mentioned, without a doubt, COVID-19 is not just going to simply end. Yes, hopefully it will become simply endemic, but there's going to be a COVID-20, a COVID-21, and all these other bacteria and fungi that are out there now. So again, thank you for your attendance.